Now we learn about bladder pain syndrome. Bladder pain syndrome. Bladder pain syndrome means it is a basically diagnosis of exclusion. Diagnosis of exclusion. Generally, if the symptoms of persist for 6 months with pain and lasting for 6 months, that is known as bladder pain syndrome. If a patient came with bladder pain syndrome, so what you'll do first initial assessment. What you'll do first initial assessment. Initial assessment, you'll ask the history, you'll ask the history, you'll ask the urinary symptoms, okay, you'll ask about pain, you assess the quality of life, okay, this is the question, okay, assess the quality of life. Then obviously first thing is you should rule out UTI, right? So UTI ruling out by means of urinary protein and culture sensitivity of midstream urine sample, okay, that and you'll physically examine her, physical examination, and you'll do that volume and frequency chart, how much volume she's taking, how many frequencies she's passing the urine. You do these things, okay. If UTI came, then treat the UTI, okay. If no other symptoms and seen, then consider other causes like infection, malignancy, overactive bladder and all, okay. Mm, this bladder pain syndrome is there, na? Once the patient voids, the symptoms will reduce. Okay, once the patient voids, the symptoms will reduce. It will reduce in 57 to 73% cases. Okay, that is important. Okay, now what is the treatment? This is very important because step wise they'll ask the treatment. Okay, so totally there are 5 steps. How many steps? There are totally 5 steps. Okay, first step is step one. Okay, first step is you will do conservative management. For example, a patient came with bladder pain syndrome. You will go for conservative management. Okay, conservative management. What is the conservative management? Pain, because pain. You'll go for analgesia. What is that? Analgesia. Analgesia for 3 to 6 months. Analgesia for 3 to 6 months. And they will ask, what is the most common cause of bladder pain syndrome? It is stress. This is also one of the question. So it is stress. So second thing is you will go for stress relief, okay, diet modification, exercise, physical therapy, support groups are available. You'll go to this, okay. So if step one, that is conservative management fail, what you'll do? They will ask this question. If conservative management fail, what you'll do? First thing is you'll refer her to secondary care. This is the answer, okay. First thing is you refer her to secondary care, okay. That's it. Next is second line, okay. Next is second line. Second line is step two. Hmm? In this, you'll go for tablets. Okay. Till now, we didn't give any medications. Now we'll go for medical management. Okay. That is tablets. Tablets is oral amitriptyline, cimetidine, cimetidine. And if this treatment fails, what you'll do? You'll refer her to MDT, multi-team, multidisciplinary team, pain management team. You'll refer her to this. Next, in step three. So already you gave tablets, right? Now what you want to go? Main problem is bladder. Main problem is bladder. Bladder is showing pain. So you give some medications into the bladder. Okay. So that is intravesical, intravesical DMSO. Okay. And intravesical heparin. Okay. And most favorite botulinum toxin A. Botulinum toxin A. Next, lidocaine. Okay. Chondroitin sulfate. Chondroitin sulfate. Next, hyaluronic acid. Okay. Chondroitin sulfate, hyaluronic acid. Okay. So chondroitin sulfate, hyaluronic acid. You can give that. Okay. And question is, intravesical heparin is there now. Generally, if a pregnant lady with bladder pain syndrome is there, then you'll go for intravesical heparin. This is the question. Okay. Next, this also failed. If this bladder thing also failed, then you'll go for step 4. Step 4. So bladder also we treated locally. What should we do? Now nerve supply is there, na? Nerve supply. You'll go for that. Okay. So neuromodulation is done. What neural modulation you can do? Sacral nerve stimulation, lateral nerve stimulation, or else posterior tibial nerve stimulation. Posterior tibial nerve stimulation. Okay. and oral oral cyclosporin A. This is the question. See, now still now these nerves only, na? These three are nerves, but only oral cyclosporin is the one which comes under fourth step. After this last step, that is 5. Now everything is done. Now we should see what is inside. Okay, what is inside you will want to see. So you keep a scope inside the bladder, and you visualize the bladder. Okay, that is cystoscopy. Cystoscopy, hydrodistension, hydrodistension. Okay, if any Hunner lesions are seen, then major surgery is considered. Then you refer her to, if Hunner lesions are seen, then you refer her to tertiary care center. Okay, this is the main management of bladder pain syndrome. Once again, I'll tell you this thing. Okay. So first, what is bladder pain syndrome? It is a diagnosis of exclusion. A diagnosis of exclusion when a patient came with pain of 6 months duration, then you can all the things are ruled out. Even UTI, everything is ruled out. Then bladder pain syndrome can be the diagnosis. You'll take the history. You'll take pain history. You'll assess the quality of life. You'll rule out UTI by means of urine routine, culture sensitivity. Physical examination is done. Volume and frequency charts are maintained. Okay, in that way. So bladder pain syndrome generally, if they're void, the symptoms reduces in 57 to 73% of the patients. Okay, so that management. Sorry for this. So management is there are 5 steps for management. Okay, 5 steps for management. Step one is conservative management. Step one is conservative management. So what if that pain is there? So you'll go for analgesia. Okay, and most common cause is stress. So stress relief. Analgesia also you'll try for at least 3 to 6 months. Then diet changes, okay, exercise, diet changes, exercise, okay, physiotherapy is given, diet changes are done, okay, supportive groups are there, you'll go for that. If it is not reducing with that, then you'll refer her to secondary care, okay, you'll refer her to secondary care. So after step one, if it is not sufficing, you'll refer her to secondary care. In there, they'll do step two. What is the step two? You'll go for oral tablets, that is oral amitriptyline, oral cimetidine, okay, oral amitriptyline, cimetidine. Then, if it is not reducing, then you go refer her to pain management team or multidisciplinary team. They, in step three, they'll go for bladder intravesical systems like DMSO, intravesical heparin, botulinum toxin A, lignocaine, chondroitin sulfate, hyaluronic acid. These are given. This is not working, then you'll go for step four. So directly you'll stimulate the nerves. That is sacral nerve stimulation, positibial nerve stimulation, or is oral cyclosporin. This is the one. Okay. Oral cyclosporin is seen in which step? They will ask this question. Oral cyclosporin is seen in step. Oral cyclosporin is seen in step 4. Okay, then if it is also not working, then you want to see the bladder. Okay, in bladder you'll go for cystoscopy. If this is not working, then you'll refer to tertiary care center. Okay, this is about bladder pain syndrome. I want to teach also about recurrent UTIs. If any recurrent UTIs are there, what to do. Okay, so if a patient came with recurrent UTI, okay, and she's unable to pass urine, retention is there, okay, what to do? So first thing, if this lady came that there is retention, then you'll ask her, encourage her. First step one is encourage her to pass urine, at least 4 hours, maximum to 6 hours. Okay, so you'll try totally 6 hours. Hmm? 4 hours generally in 4 hours she need to pass. If she's not able to pass, give additional 2 hours, that is 6 hours. Okay, then if she's passing urine, okay, you will go for Vesi questionnaire. Okay, there is a Vesi questionnaire. You will do to that female. You'll ask some like list of questions, and she'll tell those all answers and all. Finally, this questionnaire says that whether there is retention or not. This questionnaire is mainly retention is there or not there. Okay, so if basic questionnaire says retention, if basic questionnaire says yes, there is retention, then what you'll do? She already passed the urine. You are saying that there is retention. Then you'll keep in and out catheter. You know the in and out catheter, the police one or a silicone one, which will go in and out. After she passed urine, she already passed the urine. She already passed urine. You did a questionnaire in which she's saying there is retention. Then again you kept in and out. If in and out, if in and out, if in and out. the volume, the volume of the urine is less than 250 or 250 to 700 or more than 700. You see that. If it is less than 250, na, that means she already passed urine. Again, you did in and out. It's only less than 250. Then you say, okay, take 6 more hours and you pass urine again. Okay, take 6 more hours and you pass urine. After 6 more hours, you again do in and out. You again do in and out. Okay. In this again you see the volume of the urine. If it is less than 150, 150 to 700, more than 700. Okay. If there is less than 150, nothing to do. Okay. Nothing. You'll just proceed to, you'll encourage her to pass urine. That's it. Okay. If if in first part only, if it is 250 to 700, okay, if 250 to 700, again you'll insert a police, you'll keep police and encourage us pass for 24 hours. Okay, okay, try after 24 hours. If it is more than 700 and if it is more than 700, don't remove police. Keep police and review after, at least keep police for 2 weeks. Okay, and review after 2 weeks. That is same here also the same. You keep police for 24 hours. Here you keep police and review after 2 weeks. That way. You understood? This is the thing. This is about Wesley questionnaire. If in Wesley questionnaire only there is no retention, then encourage her to pass urine in 6 hours. Okay? Encourage her to pass urine in. If she's passed urine only. Okay? If she's not passing urine, not passed urine, not passed urine, then what you'll do? Obviously, if she's not passing urine, what you'll do? In and out you'll do. In and out, if again there is 150 to 200, 250 to 700, more than 700. So you people can then, more than 700 means more than 2 weeks you'll keep police. 250 to 700 means 24 hours. 150 to 200 means again you go for proceed attempt at 6 hours. Okay, again you give a chance to her. Okay, that's about recurrent UTI. Um, next there is one more topic, that is acute UTI. Okay, acute UTI. If there is acute UTI, suddenly a lady came. She's saying there is fever, there is increased frequency of urination, there is burning micturition. Within 2 days she's saying like that, and very much painful abdomen. Okay? Then first step is you will send the urine sample, mixed urine sample, urine dipstick and culture. Okay. As there are symptoms, don't wait for the culture. Start antibiotics. Start antibiotics. Okay. So when you will say recurrent UTI means if there are 3 UTIs in a year, in 1 year, if there are 3 times UTIs, okay, or more than 3 times UTIs, then it is known as a recurrent UTI. If she is saying history, that is recurrence, is already fourth time and getting this kind of thing, then you will refer her to secondary care. You will refer her to secondary care. What is secondary care? Secondary care means specialty people will be there. So only bladder people, only the kidney people, urologists will be there. What they'll do? They'll go for cystoscopy, they'll go for renal ultrasound, they'll go for voiding studies, they'll do this. Okay. So whatever abnormalities are there, they'll treat that. Okay. Whatever abnormalities is there, treat that. Even urologist did all this, there is no abnormality. All are normal. Okay. Then you'll see the age. Then you'll see the age. If she is premenopausal or postmenopausal. Okay. If she's premenopausal or postmenopausal. If she's postmenopausal, then you'll offer vaginal estrogen. Okay, because of that vagina, because of that vagina being dry and atrophy, there is UTI for her. So you'll give vaginal estrogen. So there will be good thing. Okay, even premenopausal, she's young only. Then you'll go for gag replacement. Gag replacement. Okay, and you'll follow up for 12 months. Here also you'll follow up after vaginal estrogen, follow up for 12 months. If everything is okay, UTI reduced, okay, then you will, she is in secondary care. These all people, the secondary care people are doing this, okay, urologists are doing. So you'll refer back her to or discharge her to primary care. Okay, you'll discharge after primary care. So each and everything is a question. So once again, I'll repeat this session. Okay. So bladder pain syndrome is the diagnosis of exclusion. 6 months there is pain, pain, pain. You'll ask about history and all. Okay. How to manage this? Pain is there. So first step is painkillers, analgesia for 3 to 6 months. Stress relief, diet, exercise, physiotherapy, support groups are there. If it is not working, then you'll refer her to secondary care. In case of second step, you'll go for tablets. That is amitriptyline, cimetidine. You'll go for that, and you'll refer her to MDT. You'll refer her to MDT, that is pain management team. Okay. Then you have step 3, that is intravasaically. You'll go for Damasco, heparin, botulinum toxin, lidocaine, chondroitin sulfate, hyaluronic acid. Very important is heparin, which is given in pregnancy. Then, then you have step 4, which is nerve stimulation, sacral nerve stimulation, positive nerve stimulation, and oral cyclosporin is present in step 4. Step 5, cystoscopy, heavily stationary for up to secondary care. If a woman, next concept is if a woman with recurrent UTI came, then what you'll do? You'll see whether there is retention or not. If there is really retention, then you go for you'll ask her to pass the urine. You'll encourage her to pass the urine. Okay. How much time you'll give? You'll go for 4 hours. If she's not passing, you'll give additional 2 hours. You'll give additional 2 hours to pass. So totally 6 hours you'll ask her to pass. If she's not able to pass, then you'll go for in and out catheter. In and out catheter, you have 700 ml of urine. Then you'll keep catheter for at least 2 weeks. You'll keep catheter for at least 2 weeks. If in and out there is 250 to 700 ml, then you'll keep catheter for 24 hours. If in and out only 150 to 200, then you'll encourage her to pass for urine after 6 hours. Okay. So what is in and out? You're keeping in and you're leaving out. There is no Folis. Okay. So to decide whether to keep Folis or not, you will see the volume basically. You'll see the volume. If more than 700, you'll keep Folis for 2 weeks. If 250 to 700, you'll keep the Folis for 24 hours. Okay. If seriously after giving this 2 additional hours also she passed the urine, okay, and you'll go for a Wesley questionnaire. In Wesley questionnaire, if she is saying yes, retention is there. Yes, there is a retention. Okay, yes, there is a retention. Then what you'll do? If there is a retention, then again the same thing. As there is retention in the urine, in the bag, in the what you say bladder, you go for in and out. You see the volume. Here the volume is 250, 700, more than 700. If it is 250, less than 250, you give 6 hours in and out. If again less than 250, okay, normal. If in and out 700 is 24 hours, more than 700 is 2 hours, 2 weeks. If again in and out only it is 250 to 700, you'll go for 24 hours, more than 700 is go for 2 weeks. Okay, this is about retention. If there is acute UTI, there is pain, there is increased frequency, there is a fever, then first thing you'll go for urine dipstick and urine protein culture. You start antibiotics as there are symptoms. Symptoms are present, you start for antibiotics. Okay, even though in urine dipstick and all leukocyte nitrates are negative, okay, you send for culture. Yes, you'll send for culture even though it is negative. There is no pus, then also you send for culture. And antibiotics you start, yes, you start the antibiotics. Okay, then more than 3 UTIs in a year is known as recurrent UTI. Then they will refer to secondary care. Secondary care means urologist. They'll do cystoscopy, ultrasound, voiding studies and all. If there is abnormal, then treat accordingly. If they all are normal, then you will see the age. Then the urologist will say age. Age is postmenopausal, that means something hormonal. You will go for vaginal estrogen and follow up after 12 months. Follow up after 12 months. If she's premenopausal, you go for drug replacement, follow up after 12 months. If the symptoms are reducing, UTI is reducing, then you'll discharge to primary care. Okay, that's it. Thank you.